Please look in your participant packet for disclosure information for Dennis Wagner, Alicia Cole, and for the Planning Committee. You're watching the award-winning VHA TV. This program is confidential. Duplication of this program without permission of VHA is prohibited, except for use by participating healthcare organizations.
We need to engage people at all levels and make sure that we keep the patient at the forefront by personalizing any work in the surrounding of harm to a patient.
Some of the best dialogue and best learning have come from each other talking, instead of us always giving them what we think are the best practices.
Welcome to this special VHA TV program where we'll focus on actions and learnings from the Partnership for Patients campaign. During this program, we'll discuss the latest progress being achieved by the many partners working with the Partnership for Patients. You'll see how this campaign is providing an unprecedented opportunity for hospitals, patient advocates, public and private partners to accelerate improvement and prevent all causes of harm, what we're calling prevention of harm across the board. We'll summarize key points we're learning from hospital engagement networks, or HENs as we call them, of which VHA is one, the 3,700 plus participating hospitals, patients, and other key stakeholders involved. We'll also look forward, identifying the actions to further affirm your commitment to the Partnership for Patients and opportunities to engage more partners and the remaining U.S. hospitals who have yet to join. In addition, we'll hear the compelling and, I might say, frightening story of one patient's experience with infection, which led to a list of continuing and daunting health challenges. Out of that ordeal, she has become a patient advocate and is here with us today. I'm Marty Hatley, CEO of Project Patient Care, the Chicagoland Patient Safety Coalition, one of the thousands of organizations that have partnered and aligned with the Partnership for Patients. I also am a member of the National Content Developer Core Team, NCD for short, a partner and resource to many organizations, but especially the HENs, who work with and support the hospitals in this important campaign. We're glad you can join us today for today's program. Now let's meet our special guests. Joining us first is Alicia Cole. Welcome, Alicia, a patient and patient advocate who I mentioned earlier. Alicia, why don't you tell us a little bit about you and why you're here today?
Absolutely. Well, first of all, thank you for having me here. It's an honor to be here. I am actually, in my past life, I was an actress. And the ironic thing about it is that I played a lot of doctors and nurses. And at the time I went into the hospital, I was actually playing a doctor in the fight against childhood obesity. So I like to say I'm not a doctor, but I play one on TV. So I kind of stumbled into advocacy. I was commissioned by fire. I went into the hospital for a routine procedure. It should have been for 2 days, and I ended up being there for 2 months. After that, I had 3 years of wound care center and 7 years and counting of aftercare and rehabilitation. So my experience as a patient led me to doing advocacy, and that's what's brought me here today.
Well, we're glad you are with us today, Alicia. Thanks very much for coming and joining us. We also have Dennis Wagner back with us again after an earlier program this year. Dennis, why don't you tell us a little bit about your role with the partnership?
Very good. Thank you, Marty. I'm with the U.S. Department of Health and Human Services, and I'm one of 2 co-directors in the Partnership for Patients campaign. My field of endeavor is the field of social marketing, which is all about moving the nation to action, making requests and offers among organizations and individuals to generate action and results. And we're going to be doing some of that here for those of you in the viewing audience today, so we want you to be braced. We're going to be asking you to ramp up reporting and ramp up the work that you're doing to make the nation's healthcare safer.
Thanks, Dennis. Welcome. Paul, you're the co-director. Tell us a little bit about you and your role.
Well, thank you, Marty. I am the second co-director of the Partnership for Patients. I'm just delighted to be here, especially with Alicia. We're just so glad when patients can join us in this important work. I am a physician, internist, and geriatrician by background. I've been with CMS now for over 12 years, and really, Marty, I'd say my focus is on the two bold aims of the Partnership for Patients now. I live and breathe it. We want to reduce all-cause patient harm by 40% and 30-day readmissions by 20% by the end of next year, 2014. And Dennis is going to talk more about what that means for the country as a whole and for patients in particular in just a minute. Thanks for having me.
Oh, thanks, Paul, and to all of you. Okay, we're glad to have you here for this discussion. And before we begin the discussion with our panelists, we want to give you a chance also to participate towards the end of this program. So you may want to jot down right now how you can interact with us later on. You may send an email to vhatvlive@vha.com. Or if you're watching by webcast, type in your question or comment and hit submit, and we'll do our best to answer them. Dennis, a quick recap on the Partnership for Patients. We know the bold aims, but how do you describe this campaign?
Very good. Thank you, Marty. Well, as Dr. McGann said, the Partnership for Patients is about achieving two bold aims, a 40% reduction in preventable hospital-acquired conditions and a 20% reduction in 30-day readmissions. We want patients to go home safe. We want patients to go home and be able to stay home and not being readmitted to the hospital. Achieving these two bold aims means that 60,000 lives will be saved and that millions of patients will be free of injury and will not have to return to the hospital. That's the essence of the effort. It's not defined by its budget. It's not defined by an organizational chart. It's defined by those aims. Now, Marty, the way we generate progress in this campaign is really in three central engines. The first engine is the investment that the CMS Innovation Center is making in providing technical assistance to 3,700 hospitals across the country who are teamed with hospital engagement networks. The second key engine is bringing every single federal lever that we can bring to this effort to try to generate change. That means we have partners in the federal government like the Department of Defense, the Veterans Administration, the U.S. Office of Personnel Management, and all of them have ways that they can influence national action on these two aims. The third engine, and really the largest engine, are our private partners. These are organizations like your organization, Marty, and others that are in this patient and family advocacy space that are working with patients and families to bring them into their care, but also organizations like the National Business Group on Health, unions, large organizations that provide health care to their employees are also part of the Partnership for Patients. So that's how we're generating results. Three engines, CMS investment through the Affordable Care Act, federal levers, and private partners.
Great. And there are thousands of those partners that have come together.
Thousands.
Paul, there's a lot of resources that have been gathered as part of this campaign and aligned as part of it. Why don't you walk us through what those resources are that are available to people engaged?
Yeah, Marty, I'd be happy to do that. You know, we're almost 2 years into a 3-year test on this, Marty, so I'd say we're kind of at the peak of power and resources that are available. I'm just going to go over just a few of them right now. One of them is your organization that you're affiliated with, the National Content Developer, that sort of orchestrates this as a national campaign event. They're Econometrica, and they just do so many things to help everything run smoothly. We have another contractor, the Patient and Family Engagement Contractor, that's called Weber Shandwick, and they're really responsible for having Alicia and 70 other patient advocates, and growing by the month, come together to help us achieve these two goals. They also do master classes to help train people so that they can get as good as Alicia at being a patient advocate, and we're happy that that community keeps growing. We have lots and lots of programming and other educational support that goes with this. We have, of course, what Dennis already talked about, the CMMI investments, the hospital engagement networks, the HENs. We have over the providers that are part of those HENs, over 3,700 hospitals and the thousands of people that work there. We have what we call topic-specific affinity groups. We have 9 of those right now. One of them is patient and family engagement, but there are many others. And then there's lots of other resources, Marty, we don't have time to go into, but people can check the website that they'll see on their screen, healthcarecommunities.org, and just get into a portal that will open up this whole world to them for the full court press for the last year of the campaign.
Right. And many of the HENs also have resources such as this network that VHA has that allowing us to broadcast to all of you today. Alicia, we understand in this theme of partnership that you've been working as a partner already with a QIO and with other organizations in Wyoming. Can you tell us a little bit about that?
Absolutely. I love the people of Wyoming, and I went there to speak on several occasions, and so I was asked to participate in a group called WIPEG. It's the Wyoming Infection Prevention Advisory Group, and really it's the Partnership for Patients in Action. It's a group that's made up of the Hospital Association, QIO, there are epidemiologists, private partners, and we look at education and means of, facilitating quality care improvement. One of the things that we're doing is a hand hygiene campaign, and I'm really proud of that. We've got posters and magnets all over the state of Wyoming at every kind of facility. We send out postcards to every practitioner in the state, so they're doing a lot of really good work in the state of Wyoming.
Great. Love that. And a good example of the kinds of partnerships that we're seeing really across the country, but it's wonderful. Okay. So Dennis, the main focus of the initiative, the reason why we're really here is?
Patients. We're here to do a better job of serving patients like Alicia Cole. When the Partnership for Patients was created, we made a decision to build in from the very beginning what we call patient and family engagement. And we are doing that for two reasons. Number one, it's the right thing to do, to involve patients in their care and to involve families in their care. They know their bodies. They know themselves. The second key reason is that we've learned that when patients are in the room with us, in webinars, in meetings to generate quality improvements in hospitals, that creates an urgency and a relevance to this work that is otherwise missing. Having you here today is a beautiful example of that. So those are the two key reasons that we want to bring patients and families into this work. Now, the overarching strategy that's being used by the Partnership for Patients to cause that to happen is, number one, we include patients in the activities. We talked about that. Number two, we're identifying the hospitals and organizations across the country that have already developed best practices in the involvement of patients and families in their work. And it turns out when you look for places that are doing this well, you find them. The third thing, we work then to replicate and spread those already effective practices that exist in some hospitals throughout the nation. We count and measure. You can't improve something if you're not measuring it. So we track progress on patient and family engagement, and I'm going to talk a little bit more about that in just a few moments, and we have a little graphic that will help us to explain that. And then finally, we team with other organizations that know how to do this and that can provide the sort of support that Paul described earlier. We have very powerful partners, organizations like the National Partnership for Women and Families, who have been doing this work for a number of years. We're trying to take that now to national scale in partnership with those kinds of organizations. So as I mentioned earlier, we track progress, and beginning in February, we launched a national effort to count, if you will, patient and family engagement across the 3,700 hospitals that are in the Partnership for Patients. And we count 5 things. The first thing is whether or not the hospital has a planning checklist that they provide to those patients that they know are going to come in. Patients like Alicia who are coming in for planned surgery, so that those patients can be prepared for their hospital stay and know how to do a good job of ensuring they get good, safe care. The second thing we count is whether or not hospitals involve patients and families when shift changes occur in those hospitals. The third, whether the hospital has a leader who's assigned to be accountable for increasing and managing patient and family engagement. The fourth is whether the hospital has one or more of what we call patient and family advisory councils, including, for example, patients on hospital committees that do things and make decisions like about pain management. And then the fifth area that we're counting is whether or not hospitals have patients on their board as a patient representative. Those are the 5 things that the Partnership for Patients is now counting. Dr. McGann and I are very proud that we launched this effort to begin to measure this systematically across the country beginning in February. And I'm going to share with you the results as of last month, the month of October. As of October, we know now that 2,825 of the nation's hospitals are doing at least one of those 5 things. We know further that 1,376 of the nation's hospitals are doing at least 3 of those things. And then we have this national asset, 299 hospitals that are doing all 5 of these things that can show the way, really. Yeah, it's very exciting. Now, I will say, this will be my concluding point on this particular issue, is that one of the areas we know we need to do a better job in is extending our work on patient and family engagement to vulnerable populations. Those who are uninsured, who are low income, who are the most vulnerable part of our population.
Absolutely. You know, it's important that we include those vulnerable patient populations because historically, vulnerable patient populations, minorities, the elderly, they're conditioned not to question authority.
That's right.
And so if you're talking to an elderly patient, they're less likely to speak up and to ask the doctor questions. And so we have to really work on re-educating those patients that it is okay to speak up and to ask questions. And by the same token, re-educating some of the physicians so that they know when a patient is asking questions and engaging you, it's for a dialogue about their care and not necessarily that they're challenging you know?
And we've done more to reach out to some of those vulnerable populations, and as we have, we've found more partners to bring into the campaign. So it's been just great. Now, Alicia, we've been talking about patient engagement and how we're measuring it. Really, as an engaged patient, we'd love to hear your perspective on why that's so important.
Well, it's vitally important. First of all, you know, the doctor brings the medical expertise, but as a patient, you are the expert of your own body. You know how it feels, you know how it responds. And so when you marry those two together in a partnership, you can get the best quality care. Now also, we have a saying as patient advocates, nothing about us without us. And so also, when you include a family, like my mother and my father were there with me in the hospital, patient and families working together in the hospital, family members can help with things like compliance, getting a family member to take their medication in a timely manner, that kind of thing. And then also, it can help to free up some of the resources of the hospital. A nurse who is extremely busy, you know, if you have a family member that's there helping with the ice chips or helping to see if there's something that they need, fluffing the pillows, or just helping to monitor the symptoms. That can be a real big help to an already stretched staff.
One of the things we hope to see in our metrics is whether or not patient-family engagement actually does improve outcomes. In your experience, which I know we're about to hear more about, has that been true? Are your outcomes as a patient better because of your family engagement?
My outcome is I would not be here if it weren't for my mother.
Yeah.
And her being engaged in my care, my mother and my father. But I'll say that my dad is a Marine, and he's about order and speaking up. And so he would say, when he would leave the room for my dressing changes, now you speak up, you ask questions. If there's something you don't understand, you ask them. And so we didn't even know at the time that that's one of the Joint Commission programs and campaigns is speak up and ask about your health care. Well, during that process, my mother saw a black dot and she spoke up and she said, wait a minute, we need to take a closer look at this. And it was because of that engagement of my parents at the bedside that I had the outcome I had, and I'm still alive.
So, I mean, many of our listeners would really hear that story and think about a rescue. That is a rescue that your team helped do. So let's get a little bit more into your story. And I know there are some details here that all have moved all of us, but take us through this. What happened to you?
Okay, I'll give you the quick version. I went into the hospital to get 2 fibroids taken out, and as many people know, fibroids are common in women, and particularly in African American women. So there again, we talk about that vulnerable patient population. I went in to have the procedure, and when I left the operating room, I had nausea and vomiting and a fever, and it just persisted. And I was told by the nurses and the doctor that that was routine, that sometimes that happens. People had a reaction to the anesthesia. But I never got better, and in fact, my condition deteriorated to the point that around about the 5th day, I was starting to swell and I was in immense pain. So my doctor made a little incision, a little opening in my incision, and said, well, let's see if that drains and see if it gets any better. And the next morning when he checked it, it wasn't any better. He said, okay, I'll come back in the evening and we'll take a look at it and see how it's progressing. So he didn't come back that evening, and the nurse went to do the dressing check. Well, my mother, who was being very engaged and monitoring my symptoms and the progress, saw a tiny black dot, and that black dot, it looked like if you took a Sharpie marker and you just went and did a little teeny tiny dot. And she said, well, wait a minute, what is that, you know? And the nurse said, well, it's probably nothing. And my mother said, no, that wasn't there in the morning, so I think we need to get the doctor back here, let him take a look at it and tell us what it is. Well, long story short, it took the doctor about an hour and a half to get back to the hospital, and when he got back, that tiny black dot was like a quarter-sized pustule. So it was growing rapidly. And he pressed on the call button, and the nurse was busy with another patient, and he looked at my mother and he said, Mrs. Cole, are you squeamish? And she said, no. And he said, good, because I need your help. And so my mother put on gloves, and she held my abdomen flat, and my doctor took a scalpel out of his pocket, and he reopened my incision right then and there, and, you know, did a bedside procedure and cut open my sutures. And one thing led to another. I went back to the operating room. I had 6 more surgeries. You know, I was open for 3 years, going to a wound care center for aftercare, and it just changed my entire life. I mean, I went from a healthy person who only had mammograms and pap smears to someone who has had at least 2 doctor's appointments a week, every week for the last 7 years. So it has drastically changed my life.
And among other things, you've gone back to school.
I have. I am now a Bruin. I went back to UCLA, and I'm studying healthcare leadership and management. And I find it's really helpful to my advocacy work because it allows me to understand all the stakeholder obligations and perspectives in healthcare. And so it really helps me in working and partnering to help better the system.
Well, thank you for sharing your experience. It's hard to hear. It must be difficult to tell, but it's a great example of teamwork and rescue and how we move forward. Paul, I'm going to turn to you. How does the campaign address what happened to patients like Alicia who come into our healthcare system in our
It's an excellent question, Marty. And before I get into it, I just want to acknowledge Alicia's difficulties and pain and the suffering that not only herself had, but her whole family. And I would even say the healthcare system that tried to respond and help her after that. It's an example of how the system doesn't work. And it's also an example, Marty, in the past, if we worked on one project or another, for example, in the partnership we're working on pressure ulcer and falls and maybe adverse drug events, a hospital can get good at 3 of those things, but that's still not going to help Alicia and patients like her because they also have to prevent surgical site infections. And this leads to the concept of harm across the board. And we mentioned that a little bit at the top of the hour, but the beginning answer to your question, Marty, is really harm across the board is what we're after. And that's what's different about this campaign.
Yeah, and I think that's been an exciting concept that's come out of the campaign. Alicia, you know, you've been exposed to our talk about harm across the board. What does that mean to you?
Wow. You know, from a patient perspective, if there's been some egregious harm in one area, there's a high likelihood that there's going to be some harm in another area as well. And so from a patient perspective, we really want to see that there's a system in place to address all-cause harm, to, you know, go across the different silos of care, the different wards, to make sure that there's a continuity of the system and the process and the standard of safety in the hospital.
I hear a shared mental model here. I think we're all on the same page about this. Which is great to see. Okay, Paul, results. What are we seeing?
Well, Marty, actually the news is even better than a shared mental model. We've got things that I hope Alicia will be very excited to see. As you know, we're like 23 months into a 36-month test, and we're now starting to see this come to reality. This system of safety, this high reliability, is starting to emerge. And we're about to review very, very quickly some data slides for your audience so that they can see this too. And it's a shared learning network all across the country. The first thing you'll see is what we call our momentum slide, and it shows how many of our hospital engagement networks and their component hospitals are actually reporting their data. And you'll see that top line, how it's increased, and we're now over 90% data reporting. We're going to talk a little bit more about that later. The middle line is about generating results, not on 1, not on 2 or 3, but on 5 or more hospital-acquired conditions. And that dotted line at the bottom, Alicia, that's the line that we really want to go after, because those are hospitals that have put that system in place space and are achieving what we call benchmark results on 5 or more hacks at the same time. And we have many examples all around the country we're going to go through very quickly. The first one is a slide from our hosts here, the VHA. They're one of the 26 hospital engagement networks, and that's a picture of what harm across the board looks like. That'll come up on your slide. And you'll see 2 of those arrows. When we see an arrow going down, that's harm to patients going down dramatically. And the 2 dramatic arrows there are the first one on reduction of early elective deliveries that Dennis is going to talk about in a little bit, and then ventilator-associated pneumonia, where the VHA hen has already hit the 40% reduction target, which is the bottom line there. And you can see there are 11 causes of harm there, and that's a picture of what success at harm across the board looks like. The next one that'll come up is from the Michigan hen, the Michigan Hospital Association Keystone Project, and we've got 6 harms there. Again, all of them are coming down, and all of them are heading toward the 40% reduction. If we keep going now, you're going to see an individual hospital result. This is a small rural hospital, I believe in Washington State. It's called Legacy Salmon Creek Hospital, and this is what it looks like to measure 8 causes of harm simultaneously. Rural hospitals have always had a little bit harder time because they don't have the resources, but the experience of hospitals like Legacy Salmon Creek proves that it is possible. Now here's another one. Ephrata Community Hospital in the state of Pennsylvania. Another picture of harm across the board in many, many different areas of harm, all reducing, many of them almost at the 40% mark. If we keep going now, we're going to switch to a topic which I think is very similar to harm across the board, and that is adverse drug events. Adverse drug events, it turns out, if you add up all the harms, and there are about 4.5 million every year in America's 5,000 hospitals, 30% of them can be traced back to adverse drug events. So adverse drug events is really important, and it's just like with harm overall. You see people starting with adverse drug events who pick 1 or 2 or 3 medications. And this is a composite picture of how there's been building momentum to address not just a few adverse drug events, but all adverse drug events around the country. This is another momentum slide in adverse drug events from the Partnership for Patients at a national level. And here's one from Ascension Health. Ascension Health is another one of the 26 HENs, and Jack Jordan, who's one of our measurement gurus here, calls this the next generation of measurement. This is an example of a hospital system with 80-some hospitals, soon to increase by 40%, who's tapped into their electronic health record and getting real-time data from 80 hospitals on anticoagulation and over-anticoagulation and decreasing the harm from that. It's like an early warning indicator system. Just a beautiful example of rapid cycle improvement and real-time interventions. This is one now that's addressing the same sort of thing for hypoglycemic effects and drugs that reduce blood sugar like insulin and hypoglycemics, and this is from the Carolinas Health System HEN. If we go on to the next one, what we see now is another individual hospital coming up at Schenck Medical Center. This is a medical center in the state of Indiana that's a member of our largest hospital engagement network, which is AHA-HRET, they call it, that has 1,400 hospitals in it. And they're working here, again, to reduce the adverse events from anticoagulants, warfarin, and heparin, and other such things. And you can see tremendous progress there. If we go on to our next one, it's Calvert Memorial Hospital, and this is the one that comes right here from this area in the state of Maryland. And this hospital is another member of the VHA HEN, and you can see just the tremendous reduction in harm from adverse drug events. Again, harm across the board, because this hospital, instead of working on 1 or 2 drugs at a time, has figured out how to measure all harm for adverse drug events. And if you saw on the slide, it was 77% reduction in all-cause harm for adverse drug events. Dennis is now going to talk about the exciting results in reduction of 30-day readmissions, which is a reflection of good care coordination.
Thank you, Dr. McGann. So I have 2 favorite slides when it comes to the Partnership for Patients. And the first one is the one that's on the screen right now. This speaks to 30-day readmissions in the Medicare fee-for-service population. So very large data set, millions of people being counted here month after month for the period January of 2010 through April of 2013. And when patients are checked out of a hospital, they don't want to return to the hospital for 6 more surgeries. No. That's not what you had in mind, right?
Not at all.
You want to get checked out of the hospital and stay out of the hospital. And what we're counting here are the number of readmissions, so we want those numbers to go down. And you can see that beginning in January of 2012, we've had systematic month-after-month reductions in 30-day readmissions nationally across the United States. We were at 19% for many years. You see here dating back to January of 2010. It goes back even further, that 19% average. And now, in April of 2013, we're down to 17.5%.
And
this
Dennis,
is very
this
exciting.
is a great example of partnership, isn't it? There's a lot of people working together. It's not just Partnership for Patients or HENs or CCTP or QIOs. It's everybody working together.
Effort.
That's exactly right. Quality improvement organizations are a big part of what you see here. Communities all throughout the country that are teaming up to reduce 30-day readmissions. Now, these national results are showing up now at the state level as well, as you would expect. In the state of Minnesota, we have 104 hospitals that have been able to generate a 14% reduction in 30-day readmissions since their January 2010 baseline. Exceptional results. We see the same kind of thing in states like Pennsylvania. In Pennsylvania, we have 117 hospitals that are working together with their communities, with their quality improvement organizations and others. They've been able to generate a 17% reduction as of last month. So our goal is 20%. They're at 17%, 14 months ahead of schedule. It's very, very exciting. We see those same kinds of results in 30-day readmissions at the hospital level. The example we have here comes from Fayette, Alabama. This is a hospital that started out with a baseline readmission rate of about 16%, and they're down to just a little above 6%. Those are the kinds of results we're seeing, hospital by hospital, community by community, state by state, and then nationally. Very exciting.
Dennis, you know, our goal is 20% improvement. This is almost 60% improvement.
Yep.
So when people say, well, you can't do 20% improvement, here's 60% improvement.
There you go.
And that's, again, what's different about this campaign.
Yeah, I heard the word wow escape Alicia's lips as she was looking at those data, and it was in my head, too. So we're having the same reaction. Let's turn now to one of the other impressive areas of results, and that's early elective deliveries.
Yes, so early elective deliveries.
Your second favorite slide, by the way.
My second favorite slide. That's exactly right. Certainly the top two. Sometimes it's my first favorite. In the case of early elective deliveries, this is when a hospital delivers a baby before 39 weeks, and it's elective. That is to say, the mom or the OBGYN or the hospital they've together come to a determination to deliver that baby early, before 39 weeks. Not for medical reasons usually, but usually for reasons of the convenience of the doctor or the mom, or vacation is coming or something like that. And it turns out that early elective deliveries before 39 weeks are quite harmful. As a medical doctor, Dr. McGann, you could speak to some of the harms associated.
It's really, actually, Dennis, this is one of those things we've only learned in the last 5 to 8 years or so, but we now know it's not just one harm that comes from this, it's multiple forms of harm. You can have respiratory difficulties in the newborn, you can have fast heart rate and other cardiac arrhythmias, you can have increased infections, and most of all, you can spend additional time unneeded that you'd rather be at home with your mother in the neonatal ICU. This actually, Alicia, happened to my own family. My granddaughter spent more than a week in a neonatal ICU because of this very problem. So this is very common around the United States, and we're happy to report there's actually improving results.
The good news here is that 1,236 birthing hospitals in the Partnership for Patients who are using the same measure, a measure that we can aggregate, have generated an unprecedented 48% improvement since March of 2012. 17 months of work of 48% national improvement across more than 1,000 hospitals. Now, again, and I'm going to share with you 4 fast examples on this. We see the same thing at the state and at the individual hospital level with these results. In the state of New York, 85 hospitals working together there have been able to reduce their early elective delivery rate from about 8% to below 2%. Unheard of. The Joint Commission Hospital Engagement Network, another one of our partners associated with the Joint Commission, who, by the way, have the Speak Up campaign, right along the lines of what you were talking about earlier, Alicia. They've been able, for their 23 hospitals, to reduce the early elective delivery rate from right around 5% to, again, less than 2%. I should point out our national goal here is at 5%, and these folks have got it down below 2%. The results at the hospital level are even more impressive. This is an example of a hospital in Tennessee, Morristown Hamlin Hospital, that started out with an early elective delivery rate of almost 35%, which wasn't unusual, actually. And for the last 3 quarters, they're at 0. Another hospital, Cortland Regional Hospital, this is a New York hospital, a small rural hospital. You can see they've been at 0 early elective deliveries for more than a year. We have hospital systems now, like LifePoint is one of our hospital engagement networks, that when an early elective delivery occurs, the chief medical officer of that system flies out to the hospital and does a root cause analysis with the team. People have been saying for years that healthcare needs to get as safe as aviation, and we're now starting to see some examples of what that looks like.
That's
very
really
exciting.
high reliability. It's an example of high reliability, and it's back to what Alicia was saying earlier. You're not asking just for good performance on one measure or another. You're asking for a system that tends to patient safety across the board.
Absolutely.
Yep.
Absolutely.
And we've talked about partnership, we've talked about patient engagement, but this is actually a really great example of physician engagement too. I know I've heard you both speak about the American College of Obstetricians and Gynecologists and the key role they're playing with the profession to just raise awareness about this and make this happen.
ACOG has been a key partner in this. So has the March of Dimes, who has been reaching out to moms to educate them about the risks. No mom, once they learn the risks associated with an early elective delivery, is interested in doing that.
Exactly, because you want to protect your child.
Exactly.
You know?
I think it's fair to say, Dennis, that this particular result would not be achieved without our partners outside that came in, like ACOG, March of Dimes, and many others as well.
Medical science, great. So Alicia, we've just seen a quick tour through some really, really impressive results. Yeah. Give us some feedback from the patient's point of view. What do these results mean to you as a user of healthcare?
They're fantastic, first of all, fantastic. And the two takeaways that I have from that are the fact that this validates the importance of patient and family engagement. It validates the engaging the moms and explaining and letting them know some of these risk factors that go up with the early deliveries, and also it shows that quality care is achievable.
Yes.
It's not impossible. I mean, they're exceeding some of the goals already, and we see that. So, we want to look at those as examples, and it's a win-win for everybody. When you meet high-quality standards, your patient satisfaction rates go up, and that's important. And in addition to that, the patients themselves, you have an increased quality of life. I often wonder, and I think that maybe quality of life should be an outcome measure, because you want to make sure that after your patient leaves the hospital from a successful fibroid surgery, what's the quality of life 7 years later?
Mm-hmm. Right. Let's work on that. Okay. Yeah. Okay, so back to results. Thanks, Alicia, and thanks to both of you. But back to results. What role does data play? So we've seen some great examples of reporting, Paul, and obviously you feel strongly about the role of reporting in generating the kinds of results we're seeing.
Yes, Marty, you couldn't have said that better. And it often seems like this is the dry part of the presentation. Tell me more stories or give me the human side. But I do want to make one more pitch for data. Without data, none of this happens, because you don't know where the problems are, you don't know where to improve, and most of all, you can't document and show the systems that Alicia was talking about in the high reliability. So data, although it's a little bit boring to some people, it's absolutely essential, and we have to get data reported. We're just going to show you a very quick string of images here that's going to underline this. You saw this one before. We call it our momentum slide, where we got 90% of the hospitals in the Partnership for Patient, almost 4,000 hospitals, reporting now, and that growing dotted line at the bottom, where these are the hospitals achieving benchmark status on 5 or more HACs. The next image that you're going to see on the screen comes from our host, the VHA network. And here along the bottom, the x-axis, that's what percent reporting. In other words, what percent of the hospitals in that HEN are reporting on any one of a number. Here you can see there's 27 or 28 hospital-acquired condition measures here, and the vertical axis is improvement. So the higher you are on that vertical axis, the better it is. So what you'd want to see in an ideal world, total high reliability across hundreds of hospitals, you'd want to see all these measures clustering in the upper right-hand side of your screen. Now, VHA is one of our largest networks. They're not quite there, but they're definitely improving. If you look at the next one, we're going to go down to a little bit smaller network now. This is for Washington State, the Washington State Hospital Association with Carol Wagner. Can you see how all of the quality measures, the harms, have moved almost to the right side of the screen, and a lot of them are up in that right quadrant. That means that we've got very, very high reporting in that particular network. If you go to the next image on your screen, you're going to see something that I hope takes your breath away. And this is where you have all of the hospital-acquired condition harms clustered totally over to the right side. That's 100% reporting, Marty, and that's the answer to your question. This shows it's possible. This is Dignity Health, wholly owned system, not as big as VHA and not as big as Washington, but a wholly owned system that actually has achieved this goal of 100% reporting. All they have to do now is get all the rest of those dots up to the one you can see in the upper right-hand corner, and they'll have a fully high reliability system.
It's doable.
It's doable.
It's doable.
It's showing that it's doable.
And those data points were far from boring. So when we look at the results in this campaign, we've seen that HENs, high-performing independent hospitals, entire systems of hospitals, hospitals across entire states, have all figured out how to achieve the results that we're looking for and that we're looking at. Recently, we interviewed leaders of 3 of the HENs and 1 hospital to capture what they've learned and accomplished through their Partnership for Patients efforts. So let's take a look at what they have to say.
Well, our HEN, I believe, is about the 10th largest. We have 127 hospitals participating. We have a couple of lessons. Number 1 is try to create a common vision and then drive people to that. Probably the most important lesson we've learned, however, is the whole concept of leadership engagement. We started our HEN process with a chartering process for hospital CEOs. And before we did anything, we asked the hospitals to sign a 2-page charter which basically said, this is what the Partnership for Patients is, this is what you get, this is what's expected of you. The goal of this was to have the CEOs engaged in the process so that they understood the resource burn, but also could be engaged throughout with us to remove barriers and promote change. I've observed other HENs struggling with dealing with the rural issue, how do we engage rural hospitals? And everyone knows that they don't have the resources that other hospitals do, meaning people, the number of people to do things. They also have the data challenge where their number of cases may not be clinically significant, so it's tough to gather data and draw any conclusions. That said, there are some dramatic strengths of the rural hospitals that we've learned. The relationships are already there. They're highly engaged with their medical staff, they're highly engaged with their community, and their ability, because they're smaller and less complex, it's much easier to turn a small boat than it is to turn a big boat, and they turn, and they improve. And if you can get the CEO engaged, and if you get the processes in place, we've seen dramatic changes in performance with those hospitals.
Health literacy is really a big issue out there. For the Pennsylvania HEN, the model we've really focused on is thinking about teach back sort of like a triangle, and that there's really 3 things we need to teach patients. We need to give them the what, or the action, because all humans like to know what they need to do. We give them the why, or the incentive, why that's so important to them to do that action. And then we tie it into the how, which is, I think, the piece we often miss. When you go home, how will you weigh yourself every morning? It sounds simple, but we had one patient who actually couldn't read the numbers on the scale, and until they walked through that how, they didn't realize that. And so then you have to really tie that together with conversation. People look at teach back, and they will often think that it's only something done the day you're discharging the patient. But if you do it the moment you're trying to discharge a patient, number 1, you're giving them too much information in a short amount of time, and the majority of your patients are only worried about if the car is parked in the front of the hospital so that they can go home. I think the biggest barrier we've uncovered is the patients get lost in the system, and we don't really have that smooth transition and understanding all the way to the PCPs. So what I would ask of my hospitals is work with the community, the offices of aging, the skilled facilities, home health, and really looking at what is the best plan so that we're actually looking at this from a paradigm shift of the silo to a paradigm shift of what is best for the patient experience through the whole process. I think the best word of wisdom is never forget the patient. They are our best teachers. We don't know how they live, and if we don't take the time to stop and listen to them, it's great to have the conversation, but if you don't take that 5 minutes to actually listen to what they say to you after you have the conversation, we will continue to have problems with readmission.
We take what we're learning through our immersion projects and leverage that and use that for spread of best practices across the HEN. And one of the best ways to do this is through the one-on-one interactions with our hospitals. We follow a semi-structured format, if you will. We have a core set of things that we want to accomplish, and we also let it be free form. We cover the progress on harm across the board and how that hospital is doing to see what we can learn from them and what help we can offer them through the form of coaching. We also cover their patient-family engagement activities, as well as their senior leadership commitment and engagement with all of these activities in reducing harm and preventing readmissions. We found this to be all about relationship building and helping to cement that commitment to our HEN and to our hospitals, and most importantly, to our patients in improving the patient care experience.
Clearly, leadership is one of the secret sauce elements to making all of this happen. And it's not enough for them just to be engaged. They have to own this. And by owning it, it means they have to identify with the problem. They have to work collaboratively with their frontline staff and with their colleagues in the C-suite to really have a shared ownership, a shared responsibility for bringing about the results that they need to bring about. That means things like doing walk-arounds, rounding with the frontline staff, engaging the frontline staff and the entire organization in developing what the goals are and working towards that. I think as we move forward, probably the biggest challenge for hospitals that they'll need to overcome is this whole concept of the evolution of healthcare and this transformation that we're undergoing. I think, if I was asked hospitals what would they do or what could they do to help reduce patient harm and make for a safer environment for our patients, it would really be to adopt a culture of safety and quality. So it's really introducing safety and quality into everything that they do within the organization, making it the order of business rather than an initiative that they have to address and then move on to the next one.
Parrish Medical Center joined the Partnership for Patients because two reasons. One is a natural fit, and two is the right thing to do for patients. We've been working for a very long time in looking at metrics related to both the process of care as well as to the end result, the outcome. And those metrics include not only how we care for a patient with a specific disease, but also how we prevent harm from happening and how we create a more inclusive, safe environment for that patient. And when I saw the metrics in the 10 or 11 focal areas of Partnership for Patient, that was stuff that we already did. Therefore, it gave us a venue to use our PI systems and allow us to focus on really setting the standard for our community in reaching top decile performance. One of the biggest challenges that we face internally, and I think every organization faces, is that individual, that department, that day to happen where somebody says, this is just too hard. Why do I have another initiative? Why do I have another focus? I don't have enough resources. I've got things interrupting what I've got to do here. And what I remind myself, I'm human as well as my care partners, and I ask every other hospital to remember, when is it time to start focusing on safety? The answer is now. If we wait for world perfect, we're going to be waiting forever. A focus on patient safety and prevention of harm is never ending. Just because we prevented a fall and a harm yesterday doesn't mean tomorrow we get to take a vacation. We cannot take our eyes off the ball, ever. Don't wait. Take a step and start providing the best, safest, harm-free care you can provide today.
Okay, so we heard a lot of our partners on the film talk about how hard the work is, and we are driving. These results don't happen overnight. We're driving change. So, Paul, it is hard work, and participating in the campaign means that we're making a lot of demands on people's time. What do you say to our partners here who are wondering about that?
You're absolutely right, Marty, and I think we should take a deep breath and we should admit it. It is hard work. But what I say in response, when you hear what happened to Alicia, Sue Sheridan, Helen Haskell, my own family, all of us really, our patients deserve nothing less than work to get to high reliability. And you know what the best news of all is, Marty? The data we're seeing emerge out of the last 2 years of work show us that it's possible. We're seeing high reliability erupt all over the country. We know how to do this and we know it's possible, and that gives me great energy. But Dennis has a great story and a great approach to this. I'd like him to share that with the audience.
Well, Paul, I always thought that the antidote to exhaustion or fatigue was rest. So my plan was hit this as hard as we can for 4 years and then rest for a little bit, right? That was my plan. But what I learned, and I learned this from a gentleman who wrote a book, his name is David White, is that the antidote to exhaustion is wholeheartedness. Wholeheartedness. And I'm seeing it in this campaign. I'm seeing hospitals, providers that are working hard every single day, generating results, and getting more energy from those results. It's sort of like one good thing leads to another, and you get on this upward spiral of achievement and energy and wholeheartedness. And I believe, and I see, and I experience myself, that when we bring patients into this work, that wholeheartedness, that energy, it increases. It doesn't decrease.
That's right.
So the beautiful news of this effort, I think, is that the more we achieve, the more energy we get and the more capability to do more. And it's I think, all about wholeheartedness.
That's right, that wholeheartedness and that passion to really make it happen. It's energizing, and for lack of a better word, it's infectious. In a good way.
And Dennis, I've heard you say that we're not winding up, we're not winding down, we're winding up.
We're winding up, that's
And
right.
That's another, I think, inspiring thing. I hear from patients, too, the wholeheartedness is there. They have a new confidence, a new trust, a new hope, frankly, that we can really make the change because we are making the change.
And what happens, Mari, is this becomes the new normal. That's what all this is about. There's a transition, but eventually, hopefully for my children, this will become the new normal.
Right.
And we're getting feedback from our hands that that new normal is happening. Okay, so we're running out of time now, so thanks to all of you for engaging our audience in this very inspiring and impassioned and compelling discussion. And now it's time for you in our audience to interact with our panel. Again, you can send us comments or any questions you have in one of two ways. Send an email to vhatvlive@vha.com, or if you're watching by webcast, type in your comments or questions and hit submit. Let's take a look now at some questions that we have had come in. Okay, so we have a question here about leadership engagement. Leadership engagement is critical. How can hospitals engage senior leaders to generate the kinds of results that we're seeing today? Who wants to take this first?
Well, I think that engaging the leadership is imperative. I mean, it's got to start at the top. You can't tell your staff, your frontline staff, do this, do that, we believe in patient safety, and not role model that. Make the resources available. Allocate the funding, be there for the support, you know. So it's about walking your talk and really leading by example, being a servant leader.
And I would just say that one of the practices that we're seeing in hospital engagement networks that is remarkably effective is what they call executive rounding. You talked about walking the talk, and what this is the executive team making the rounds in the hospital and studying whether the safety processes are in place that are necessary to ensure that we're reducing harm across the board.
Exactly. Actually seeing firsthand for themselves.
It's one of the key practices that's working.
Okay, we're also seeing, I think, some of our PFE metrics align a little bit with our leadership metrics, so the two seem to go together, at least in the data that we're getting preliminarily. We have a question on CAUTI. You mentioned CAUTI as an area of concern. And what more do we want to say to the field today about CAUTI and our plans for CAUTI going forward?
Well, once more, Marty, there's good news on CAUTI. We have this national perspective and national data set that does show that at a national data set level, it's lagging behind the other harms. But at the same time, this is the value of a learning network. When you dig down into hospital engagement networks and individual networks, and there's several examples of this, but I'll just quote Dignity here. In Dignity Health, they have actually implemented changes when they saw it wasn't happening to get the CAUTI rates down, and they're posting success now. So another advantage of a learning network is that we know how to do this. Dennis, you want to describe what they told to you directly about this intervention that they had that got on top of it?
Unbelievably exciting. An extraordinary woman in Dignity named Wendy Kaler. Wendy Kaler is an infection preventionist. And she said that when we got involved in the Partnership for Patients in Dignity, we were asked, the infection preventionists were asked to come out from behind our desks and go out on the floor. And they were taught how to have what they call courageous conversations. Now, a courageous conversation means the infection preventionist is regularly and routinely, like thousands of times over a period of years, interacting directly with providers on the floor. And the questions they're running on are, do we need to put that catheter in? Is it absolutely necessary? Because catheters can lead to infections. We don't want them in there unless they're necessary. The other question, can that catheter come out today?
That's right.
So it's in, but can it come out today? And the third question, I see we've got a catheter. I'm hearing it can't come out today. Are we documenting in the record why it has to be in today? That simple but very diligent practice by infection preventionists, having courageous conversations every day with nurses and physicians throughout the Dignity system, is generating a dramatic reduction in clotting across the 35 hospitals in Dignity.
And I hope our audience hears the similarity here between Alicia's mother and what Alicia went through and what Dennis said. I think this is one of the universal truths of learning that's emerging out of our network.
Absolutely.
Great. I do want to pay attention to the questions. The follow-up to that question is are there other areas of concern or other areas of emphasis that we want to bring to our listeners' attention today?
Well, if I could jump in on that one real quickly. We shared with the audience that we're seeing really spectacular results in Medicare fee-for-service 30-day readmissions, and we're seeing examples of dramatic improvement at both the hospital engagement network level and also at the individual hospital level. But we need to do more. Nationally, to achieve the 20% reduction, we're going to have to seriously ramp up work on 30-day readmissions. We know it's possible because networks are demonstrating it's possible.
Pennsylvania.
Exactly. But we've got to hit this one harder. So we have a request. Remember? Requests and offers, social marketing. Our request to the hospital providers and executives that are tuned in today, to the quality improvement organizations that are leading on much of this work, is really, ramp up the action and activity on 30-day readmissions. Patients don't want to come back to the hospital.
No, we don't. And that again speaks to teamwork and partnership. I know a great example from my personal life with my sister, Ohio Health and the Westerville campus in particular. We had an occasion, my sister had to go to the emergency room, and man, my kudos to them. They're working as a team. The pharmacist comes in and speaks with you about your drug reconciliation. The doctor goes over the discharge paper with you. The nurse came in and she sat down and said, what questions do you have? How can I help you to be comforted before you leave out and assured? And it was just a real patient-focused discharge plan that they did, and it was a wonderful example. And if we can take those kinds of models and just transport them to different facilities, we can see those numbers go down.
Wow. We have a question about ADE too, and we've got about a minute left. So, we've hit this as a big priority, a big source of harm. What more can we do to reduce ADEs? I need about 20 or 30 seconds from each of you.
Well, I'll start. I'm going to go back to this sort of next generation of measurement. There's been a big push with the meaningful use incentives to get electronic health records into every one of the 5,000 acute care hospitals and also every one of the physician offices around the United States. And this electronic reporting in real time that can scan across hundreds of different medications and get it back in and then show providers how they're doing on anticoagulation, I think that's the single biggest advance. And people with EHRs can adopt this tomorrow if they choose to do that.
All right. Dennis, very quickly.
Yeah, real quickly, I'd say in hospitals, bring your pharmacists into this work. Get that pharmacy department involved. They want to contribute. That's number one. Number two, we know that the highest risk adverse drug events are in three areas: anticoagulants, opioids, and hypoglycemics. So start there. Work on those three in particular. That's where a lot of the harm is.
Okay. And Alicia, we are out of time, but we're going to have you back to talk more about this in one of our very, very near future events. So with that, we're out of time for today's broadcast.
Wow, that went fast.
Yeah,
it did. If we didn't get to your questions from the audience, we will get back to you about them. We'll respond to them in writing. But I'd like to thank our guests, Alicia Cole, Paul McGann, Dennis Wagner, as well as all of those who we interviewed on video. Also like to take the time to thank the VHA HEN for supporting this program, and thank all of you who took time out of your busy schedules to join us today. Please take a moment to complete the program evaluation, which will be emailed to those who registered in advance for this event. If anyone on your team could not view today's program live, it will be archived. There's a recording that will be posted for an on-demand viewing on VHA's website at www.vha.com/. www.cctp.org/pfp/2013. And watch for information coming soon regarding educational programs available to all Partnership for Patients participants. And please join us for our next Partnership for Patients program, where we'll focus on CCTP, that's community-based care transitions. I hope you can join us then. Be sure to review the program supplement, which you can download from the event materials page. There'll be more exciting results there. That's on the registration site. It contains a list of the many resources available to you as part of the Partnership for Patients, such as the Community Practice website and the topic-specific affinity groups. And now for Partnership for Patients, I'm Marty Hatley. Thanks so much for joining us today and watching this event. Thank you.